Before we started the press conference, I wanted to make a few comments today about a passing of a great American, a great West Virginian, Robert C. Byrd. Without his support, this very building wouldn't be here. His support dates back to when he cast a vote in the legislature of West Virginia in favor of construction of this School of Medicine in Morgantown. He served in the U.S. House when he was first elected in 1952, served in the Senate since 1959, and is the longest serving member of Congress in the history of the United States. He loved WVU as much as he loved the state, I think. He believed strongly in the pursuit of knowledge and scientific discovery, and he was a brilliant man himself. From his humble beginnings, he knew so very well that the Appropriations Committee was the place to be. And whenever he had a chance to show his affection in every way he could, and certainly he could entertain us in many ways, whether it was playing the fiddle, dancing, singing, and he could recite from the U.S. Constitution, as I think everybody in the country knows. He was a great patriot, and I'd recommend that we have a moment of silence in gratitude for his extraordinary life of service. I'm Julian Bales. Can we go ahead and get started with the press conference? Yeah, I'm Julian Bales. I'm the director of the Brain Injury Research Institute. Ben Amalo is the co-director. And we're here today. I think we have an important announcement. The Brain Injury Research Institute is affiliated with WVU. Our mission is to study the causes and look for potential treatment and maybe prevention of traumatic brain injury. We have a special interest in chronic traumatic encephalopathy, or CTE, which we've studied now in approaching 30 cases since Ben Amalo first discovered it in football players in 2002. I would like to recognize today Dr. Jennifer Hammers. Jennifer, I can't see you. Where are you? There you are. That should be easy. She's been very integral to our work, as well as Mr. Garrett Webster, who's also been a very important part of the BIRI. Chris Henry, the former WVU and Cincinnati Bengal player, died December 18, 2009 in a tragic accident where he fell out of the back of a moving pickup truck. With the permission of his family, particularly his mother, Carolyn Glaspie, who's with us today. Would you mind standing up, Ms. Glaspie? We have had thank you. With her permission, we've had the opportunity to study Chris's brain post-autopsy. And for us who are maybe in some senses detectives of brain disease, this is an incredible opportunity, and we greatly appreciate because it adds to our knowledge. While the examination of Chris's brain showed that certainly he died of the effects of an acute brain injury with brain edema or swelling and brain herniation syndrome less than a day after he fell out of the truck, this was superimposed on findings of chronic traumatic encephalopathy, or CTE. Using special microscopic stains, similar to what you would use if you were looking at someone with Alzheimer's disease or dementia, we found characteristic changes that we've seen in other players, usually older players, who have an accumulation of tau protein. They also have inflammatory changes and white matter changes that we're seeing as part of the picture. So Chris's autopsy has shown that using the detailed staining techniques, he did have CTE. In addition, we think that Chris exhibited many of the characteristics, or at least some of the characteristics, of the neurobehavioral syndrome of CTE. Now, we don't know for sure if there's a cause and effect. We're today reporting our findings. But At age 26, Chris represents the youngest active player still playing in the NFL, so diagnosed. Perhaps one of our other most important findings is that we think we may be seeing a genetic trend, that Chris is now in the 70% of those diagnosed with CTE who have a special genetic sign, and that is the apolipoprotein E3, or ApoE3, it's known as. And perhaps that may be a clue as to who's at risk for this to develop. I would like to now introduce Dr. Bennett Amalu, the co-director, who will take you through pictorially to show you our scientific evidence and a description of what was found. Bennett?
Thank you, Julian. Good afternoon, everybody. As Julian had said, I'm the co-director of the Brain Injury Research Institute. We received Chris's brain from North Carolina a couple of months after his death. His brain had been previously cut by the forensic pathologist who performed the autopsy. But we were able to still put the brain together and examine the brain by gross inspection and with the aid of a dissecting microscope. Interestingly, Chris's brain looked normal by naked eye examination outside the acute traumatic injury he suffered, which was fatal. And this was reminiscent of the previous cases we have seen. By naked eye examination, by routine CT scan and MRI, the brain will look normal. There was no evidence of brain atrophy that you would see in Alzheimer's disease. There were no other findings that may be indicative of severe brain damage. But we took sections of Chris's brain, extensive sections. We sampled his brain and subjected his brain to a battery of immunohistochemical stains and silver impregnation stains. There were, on the whole, over 200 slides of his brain we examined, and we have selected some pathognomonic or diagnostic features and microscopic pictures of the stains we did, which I would show you. Now, immunohistochemistry is a highly sophisticated tissue technology that evolved, or we began to use at about the early 1980s, but the technology has advanced. We are getting better at it. We are beginning to look at a greater number of brain proteins. Essentially, what you could see here is a photomicrograph or a microscopic picture of a normal brain that has been stained with an antibody or has been subjected to an immunohistochemical stain. This is about 400 times the magnification of the normal brain. And just in the layman's terms, what you could see is just a blue background, like a sea, a blue sea, with scattered normal appearing brain cells. You don't see any brownish discoloration or any other discoloration outside the bluish color. Now, a section of the part of the brain that represents Chris's mind, the prefrontal lobe. You wouldn't need to be a pathologist or a physician to see the remarkable difference. This is a 200 times magnification of immunohistochemical stains using polyclonal tau protein. Polyclonal tau protein. And what you could see is this diffuse brown discoloration with numerous, abundant neuritic threads. Pardon the jargon, but these are abnormal fibers that have been damaged by accumulated abnormal proteins. There are millions of them. And in the brain cells themselves, you will see accumulated abnormal tau inside the brain cells. This is completely abnormal, especially in a 26-year-old individual. And now, this is 600 times magnification of Chris's brain. And you could see the large numbers of dystrophic neuritic traits, NEURITIC. These are all abnormal. You should not even find one neuritic trait in the brain of a 26-year-old. And then you could see the brain cells, the large accumulation of the abnormal tau protein. You could see different stages of formation. And you could see actually a dead brain cell because the tau protein kills the brain cells. And these are the same histomorphologic findings we have seen in all the previous cases we have done. This is diagnostic of chronic traumatic encephalopathy. In addition to the abnormal tau accumulation, there was a low-grade inflammation of Chris's brain, and also low-grade damage to the white matter, to the connecting nerve fibers between the brain cells. We have observed specific patterns of CTE, or what you may call subtypes, which we plan to publish soon in a highly respected scientific journal. We have actually designated it the O'Malley-Bales classification. Hopefully it will be published. And it will assist other doctors across the world to diagnose and identify this disease when they see it. We have also, as Dr. Bales has stated, observing other risk factors, specifically genetic risk factors. We've been looking at a specific gene in all our cases, and we are observing an overrepresentation of a specific type of gene. Thank you so much.
Thank you, Dr. Amalo. So we have time for questions. Dr. Amalo, you want to take them from your initial discovery and Garrett's father, Mike Webster, and the evolution, the road since then?
Well, when we started, remember, we were not looking for this. We were simply doing our work meticulously, looking for answers. And we came across this in 2002, Mike Webster's brain. We did not think we came across something important. We just thought as doctors we were advancing the frontiers of medicine. It was not until we came across Andrew Waters, the third case, because in medicine, a third case describes a case series. The third case indicates a trend, that we realized that we may actually be identifying a trend that had gone unnoticed.
And you also talked about the neurobehavioral syndrome. Make that relatable for our viewers. Describe what somebody with that, how would they behave?
Well, typically, they have problems with relationships, whether it's marriage is also a problem, leading to separation and divorce. Business relationships and business success goes on to depression, many times suicide, and sometimes substance abuse, drugs and alcohol. So that's typical. And Chris Henry did not have that entire spectrum, and we don't know for sure if there's a cause and effect here. What we're trying to do today is to report our findings, what we've seen scientifically, and that will maybe be for others to help decipher.
And then how do you know that the pattern you're seeing is from football and not from lifestyle factors?
Well, we don't know completely. We think the leading cause of this, and I think it's pretty well accepted, is is multiple traumatic brain injury. The official term, is mild traumatic brain injury or concussion. We are fond of, as many other researchers are now, is saying that, there may be nothing mild about it, especially if it's repetitive. And we've seen in our series, we've seen it in military victim or military veteran, previously diagnosed with PTSD. And so it's a gamut. It's probably a spectrum of exposure. And perhaps we're onto something, as we mentioned, with a genetic trend here. But I think we, as Albert Einstein once said, apparently that's why they call it research, because we don't know exactly what we're doing and we don't have the answers, so we're pursuing it.
With Henry being a receiver, was it particularly surprising to you? I mean, we know that receivers are subject to a pretty intense tackle here and there, but they're not typically leading with their head every play like the linemen. Was this particularly interesting to you that he's so young and a wide receiver?
It is very interesting, and my opinion is that it's maybe not necessarily the head impact, hitting your head. It's the motion of the head. It's the movement of the human brain inside the cranium, which floats in a bath of cerebral spinal fluid, so there is room for movement. There's the potential for rotatory mechanisms as well, rotation injuries, rotatory injuries. So it is, his position is not, and he wasn't known. That brings up another question of, could there be these injuries which occur and don't rise to the level of a diagnosed or recognized concussion? Would you want to add something to that?
Well, the underlying causal factor really is repetitive brain trauma, and you can have brain trauma without impact, like Dr. Bales had said, the so-called acceleration, deceleration, or the rotational injuries. The brain floats freely in your skull. So if you're moving very quickly and suddenly stops, the brain bounces forward and backward and sideways in your skull. And like Dr. Bales has referred to, concussion is the end of the spectrum. You could have subconcussive impact that may not result in immediately incapacitating symptoms, but could, over time, with repeated episodes, result in significant damage.
What are your findings mean for current football players or even future football players?
Well, for current players, I would like to acknowledge all the changes, the dramatic changes which have occurred toward the end of last season and which will carry forward for next season, such as mandatory not returning to play if a concussion has been diagnosed until it has been cleared, the availability to get expert opinion or second opinions or specialty opinions, the use of neuropsychological testing, since most of the time these injuries don't show up on any sort of brain imaging studies, the education, the awareness, really from the NFL on down. And so I think there has been more, we've been saying for the last few years, there's been more discovered about concussion or repetitive brain injury, whether it's for military or athletes, than we ever knew before. And I think there's been, in both the military and in organized sports, I think there has been more of these changes. So I applaud that. I think we need to recognize what the NFL has done and the NCAA, and I think all the way down through the National High School Federation and even youth football, such as Pop Warner. So I think there has been tremendous changes, and I think this is maybe we're seeing a snapshot in time that we don't quite know where to put this young active player in perspective.
When you talk about the way the brain moves inside the skull, is there any way to prevent this if that is the only way that this happens?
Not that we know of, and I think that one of the changes which needs to be strongly considered and may be at many levels is trying to take the hit of the head or the motion of the head out of the game as much as we can. Take the head out of the game, and I know that's I played 10 years. I know that's impossible completely, but there is probably ways in practice and other fora that can be minimized. The gratuitous, unnecessary, or obligatory head contact could be, I think, significantly reduced, and I think that's something that can be done right away.
You talked about such things as leading to alcohol abuse or substance abuse. Which comes first on that? I mean, are you sure that that area of a life might not cause the problem also?
Well, I'm not certain we're sure of anything completely, Bob. I think that to our knowledge, there's not a drug of abuse such as anabolic steroids or alcohol that causes brain cells to degenerate like this. The only known cause is traumatic brain injury. There could be others, and we're not discounting that possibility.
Well, in disease modeling, we have the so-called underlying cause and other contributory factors that may either accentuate or ameliorate the disease process. We believe the fundamental underlying cause is repetitive trauma. Then there could be other contemporaneous factors that could contribute, accentuate, aggravate, or ameliorate the disease, like alcohol abuse, genetics, and other environmental factors. But a very well-established fundamental underlying cause is repetitive traumatic brain injury.
Chris had some bizarre behavior during his lifetime, both here at West Virginia and in the professional ranks. Do you attribute that to this, or do you know that that this is part of it?
We don't attribute these changes that we've seen to his behavior. We don't know for certain. It certainly raises the question and raises our curiosity, and it's a very striking, abnormal brain examination that his behavior is similar to some of the other victims or ones diagnosed with CTE. But I don't think we can make that association completely, and we're not saying there's a cause or effect. We'll leave that to others and further research.
Dr. Amalu, back in February, I spoke with you and you were talking about treatment for CTE and whether there would be clinical trials starting. Can you tell us where that stands?
Well, it's one of our objectives to perform research into the diagnostics of CTE in living people and into possible treatment. We have made some preliminary attempts. We are still moving forward with it. We have actually identified specific drugs that could target and stop the formation of tau at specific stages. But for BIRI, it remains our objective, and we are working on it. Do you want to make a
Oh, I
statement?
agree.
Dr. Bales, you were saying that by taking the head out of the game, you might be able to prevent something like this from happening. Maybe that's not, like you said, it's probably not going to happen totally. Is a newly engineered helmet, will that help even more? Or is it not even a helmet issue, that it's going to happen anyway?
Well, I certainly encourage and support helmet design, redesign, helmet technology, and I think it is very important. But the immutable fact is that Homo sapiens have a brain which is floating in a bath of CSF, or cerebral spinal fluid, in this skull. And at some point when the skull stops, the brain is going to continue forward and reverberate back, maybe a second time. And then there's always the potential for rotatory injury. And that's why this, I think, was first described in boxers who have a lot of rotatory mechanisms with punches to the jaw. So the football helmet has this face mask, which in a way is like a fulcrum, which may also, give a propensity for some rotatory mechanisms. So I support and fully encourage the best helmets we could possibly have and design, but I think that, again, my personal opinion is that the velocity of the impacts in football now at every level are so high that we need to begin to reduce the head impact or the head motion as much as we can. Well, one is enforcing rules which are already on the books. The so-called spearing rule was first written in 1976. It's been recently modified. At the NCAA level, the NFL has come out with stricter, I think, penalties, including mandatory ejection for a definite head-to-head contact. I proposed a couple years ago, for instance, why don't we take the linemen out of the three-point stance so they don't have this obligatory, mandatory head-to-head contact? Why don't you start them off in a squatting position like they do on pass protection plays anyway? That was not embraced at the time. But I think that innovations like that, rules changes and others could lead to reducing this head impact. As I've talked to coaches around the country, I think there's a greater awareness, and I think that head contact during practice, except when absolutely necessary, is going to be eliminated or markedly reduced. So I think common sense measures could go a long way immediately, just like we did several years ago with dehydration and heat stroke and the importance of rehydration. I think common sense could be very, very helpful here.
Is it possible to determine if this condition weakens or compromises the brain where a trauma or sustained trauma over time could be more severe than maybe expected or even fatal?
Yes, it's very well established in the pathology of brain trauma that repetitive trauma, not just physical trauma, other types of insults to the brain exhibit a cumulative effect, cumulative outcomes. So assuming Mr. A was playing soccer, football, name it, sustains a mild impact, and within a short period sustained a repeat impact. The brain cells remember the impact, and the outcomes are cumulative in an exponentially multiplicative fashion. And yet, the so-called second impact syndrome, you sustain an impact to your head or a concussion, and you're not taken out of play, and you sustain a second concussion within a short period, yet it could result in sudden death.
Do you anticipate this discovery having any kind of impact on the negotiations with the players' contract in the NFL?
I really don't have an opinion on that. I serve on the Players Committee, the NFL Players Concussion Committee, and I know there's the CBA coming up this year before this season, the collective bargaining agreement. So I don't know. Maybe their representatives could answer that for you, or the players, their response. I haven't. This is just announced today, so we have not.
Would you expect to find this in other players? If you were, you can't them guys that are active, obviously, but would you expect if you did that you would find it?
Well, there's no way to diagnose CTE in a living person. We have hopes for a special brain imaging test. Maybe biomarkers is a way to discover that while they're still living, but so far it's only through autopsy. So I'm not certain if how many or to what extent you would find it in current players. But the players that we have autopsied all had a very common neurobehavioral syndrome. I suppose if you had a subgroup who had those issues or those symptoms, then perhaps there would be, I wouldn't be surprised if there was a percentage of those who did have something similar, but I do not know the answer to that. Do we?
Well, in boxers, it's been established that about 20% of boxers will manifest the full spectrum of CTE. However, we've looked at 9 NFL players, and all 9 were positive. We had one control that did not manifest the behavioral patterns, which was negative. As we speak, we are looking at 2 more cases of deceased NFL players young. Hopefully, we will be announcing those later.
As far as diagnosis, long term, I guess, but the fact that maybe you determine there's something genetic to it, how useful can that be? Maybe being more advanced, I guess, in discovery.
So I didn't get the question.
Just with regard to, you said you might have discovered something that could reveal it's a genetic condition. Is that at all useful in purposes of future diagnosis?
Well, as you may know, in most diseases, you have a multifactorial, multifaceted pathoetiology or causation mechanisms. We know that there are genetic proclivities and genetic predispositions to most diseases. So identifying a genetic marker or surrogate marker as one of the risk factors will be very significant.
Anyone else? Okay, well, I guess we will conclude. Dr. Amalo and I will be around. I think Ms. Lasby will be around, and if you have any further questions, we'll be around for a little bit. Thank you for coming. Thanks, Maria.